Has this ever happened to you? You're walking down a flight of stairs, plodding along, and maybe you're in a hurry, or maybe you're preoccupied, and you find that instead of you controlling your feet, suddenly gravity is controlling the weight of your body, and you slip, you misstep, you fall. Hard. Mostly because you weren't expecting it. We see allergic reactions all day, every day, from a small bug bite to a full body breakout to regional swelling. And we're okay with it. We plod down the path of antihistamine, maybe a steroid, and see you later. That path serves us well, for the most part. But our allergy downfall, anaphylaxis, is just one distracted footstep away.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Allergy to allergic reaction to anaphylaxis, it's not always a linear, stepwise progression. In fact, the presentation of anaphylaxis may be abrupt, without red flags in the past medical history or some warning signs of the present illness. It's the unexpected slip and fall into a neurohormonal abyss. We have to be ready to find it and treat it rapidly. Let's do a brief review of exactly what we're talking about here and do a deeper dive into some of the finer points. This may just help us save a life. Why do we have allergies in the first place? I guess we could make up some teleologic argument that perhaps we have allergies because, once upon a time, sensitivity to certain plants or things in the environment was a good thing. Stay away, danger, poison. Or we could make an argument based on coherentism or utilitarianism that our immune system is needed to protect us from microbes and allergy is just a necessary evil, a tag-along, the cost of doing immunologic business. Regardless of where your epistemology gets you, we gotta deal with this life-threatening anaphylaxis. It's an acute, sometimes life-threatening multi-system disorder, all because of those pesky mast cells. You remember those guys. Mast cells are the rigid hall monitors in school. They look for anyone out of place in the circulation, and when they see them, they send out the alarm. Mast cells have a good memory, and once they come into contact with an allergen that has been bound by serum IgE, all immunologic hell breaks loose. Once the mast cell is armed with an allergen IgE complex, the mast cell is locked and loaded. It shoots out pro-inflammatory markers, including histamine, leukotrienes, cytokines, chemokines, aldokine. Anything can bind to IgE. It just depends on your particular brand of IgE, which means foods, meds, grass, pollen, chemicals, microbes, dander, insects, general bad vibe juju, all of them can be culprits, and we might not figure out what it is acutely. Our goal here is early recognition of anaphylaxis. It's perfectly okay to overcall and overtreat. Mostly because in practice, the literature shows that we do the opposite. We often underdiagnose and undertreat, especially in the extremes of age. Later, we'll talk about yet another way in which infants can be little tricksters. The National Institute of Allergy and Infectious Diseases has established criteria for anaphylaxis. Not so much to be stringent, but more to alert us to the diagnosis. Now, sometimes professional societies give us guidelines that are an unusable patchwork, more of an officious statement that doesn't seem to help anyone. But in this case, they're great. The NIAID not only gives us these guidelines that are helpful, but their criteria have been studied for accuracy and validated. In the Journal of Allergy and Clinical Immunology, Campbell et al. Performed an interesting study. They retrospectively looked at cases of anaphylaxis before the National Institute criteria were published, in addition to a control sample. They applied the criteria and found that their sensitivity was 96.7% with a specificity of 82.4%. There was a high inter-rater reliability as well. Remember, this is the measurement of how well two or more individuals will agree with the assessment. So, not to keep you in further suspense, here are the standard criteria for anaphylaxis. Anaphylaxis is very likely when you see any one of the next three scenarios. Scenario 1. Acute onset of skin or mucosal involvement. So, hives, pruritus, flushing, edema to the lips, the tongue, the uvula, plus either respiratory symptoms like wheezing, stridor, hypoxia, or blood pressure or signs of poor perfusion. So, skin plus wheeze, skin plus poor perfusion. That's anaphylaxis, scenario 1. It's comforting to know that there are skin or mucosal signs present in up to 90% of cases of anaphylaxis. Very helpful. Skin plus. Scenario 1 is basically telling you, hey, it's not just hives. Look, respiratory distress. Or, look, poor perfusion. It's anaphylaxis. Scenario 2 now mops up the rest of the cases in which skin signs may not predominate. So, Scenario 2, or in the guidelines, Criterion 2, requires 2 or more of the following with an acute onset. Gastrointestinal symptoms, like crampy abdominal pain, profuse nausea, vomiting, or diarrhea. Respiratory symptoms. Low blood pressure or poor perfusion, which includes unexplained clues like syncope or even incontinence. 2 or more of these in the right context, and you got anaphylaxis. Of course, if you have any one of the above plus skin signs, slam dunk anaphylaxis. You can see that the second criterion allows for a global picture. In other words, if you have more than one organ system distressed and you don't know why, maybe it's anaphylaxis. And lastly, Criterion 3. Acute onset hypotension or poor perfusion for no other reason. Now remember, shock in children may be tachycardia only. But this isn't the ticked-off, red-faced, angry, screaming child who happens to be tachycardic because he's upset. This is the child who may look pale with tachycardia, or have cool, clammy skin without a low blood pressure. Remember, children often present with compensated shock, tachycardia that is still able to support the cardiac output. Hypotension is a late and ominous sign. As a quick review, for infants younger than 1, hypotension is less than 70 millimeters of mercury systolic. For ages 1 to 10, it's 70 plus 2 times the age. For children over 10, it's just like an adult's 90 millimeters of mercury. Of course, this is all relative. These formulae are not hard and fast. These are very, very low blood pressures. In fact, they are the 5th percentile of systolic blood pressure. Don't wait until they technically qualify. Listen, if you see a nice little old granny with hypertension who presented with a BP of 100/60, would you say, no problem? No, because that is likely low for her. Same in children. Contextualize, don't rationalize. Sometimes people may ask about children who are very small, like premature babies or neonates. My rule of thumb, with the big caveat that this isn't based on literature, it's just based on experience and some horse sense. For preemies and neonates, their gestational age in weeks is usually their normotensive mean arterial pressure in millimeters of mercury. Again, don't be a bean counter with blood pressures. You're not an accountant of measurements. You are a medical artiste. That is, you use your scientific principles coupled with your own intangible medical wit to pull the trigger. So, maybe a 9-year-old boy with a history of a bad peanut allergy. According to what the babysitter says, he just has a little bit urticaria. Maybe there's a little flushing. Are you really going to wait until he's hypotensive? But wait, does he strictly qualify under the definitions? Just do it. Give him the epinephrine. The makers of the guidelines will thank you for using your common sense, and more importantly, your patient will do better. Okay, you get the idea. You've treated anaphylaxis before. I'm not talking any new revelations here. So maybe it'll help if we do our deeper dive in a question and answer format so that we can focus on a few issues that we just don't seem to have the time to discuss during a busy shift. Here goes. If anaphylaxis can present so variably, how often do we see skin or mucosal involvement? It turns out we're lucky here. As I mentioned before, approximately 90% of episodes of anaphylaxis will include something like urticaria, flushing, itching, swollen lips or tongue or uvula, or even conjunctival swelling. It's a little reassuring that anaphylaxis will usually show its familiar calling card. Okay, so how often will we see respiratory signs and symptoms? I'm glad you asked. Anyone working with me, I tell them that if you see hives, the first thing you should do is listen to the chest. Rash plus wheeze, we know where we're going with this. It turns out that respiratory signs and symptoms occur in about 70% of episodes of anaphylaxis. It's a little tricky here because that doesn't mean no wheezing, no problem. It could mean that there's maybe a sensation of throat closure or just a feeling of shortness of breath. Both of these things could be anxiety, but it's better to assume the worst. You may hear stridor without wheeze, also something to react to now. How about GI symptoms? How often do they occur? The literature quotes up to 40% of cases of anaphylaxis will have some nausea, vomiting, diarrhea, or crampy abdominal pain. In practice, I don't see this as often, and maybe that's just me. But I think the takeaway from this is that if you see a rash plus acute onset vomiting and diarrhea, just think about anaphylaxis. It could still be a virus, but then again, a child with acute gastroenteritis and a viral exanthem looks relatively well. A child in anaphylaxis does not. Just keep GI signs and symptoms in mind. How about cardiovascular signs? If someone is in anaphylaxis, shouldn't they be in shock? Well, as we know, it's all a spectrum of disease. The young teenager who sees hives on her skin, hyperventilates, and passes out. Could she just have a little hives and an overactive imagination? Or could she have what up to 40% of people with anaphylaxis have? Dizziness, syncope, tachycardia, or hypotension. Think about and treat worst first. Okay, I know how to identify anaphylaxis now. What about the time course? If it didn't happen right after the exposure, then maybe it's something else? What time course can I expect? Well, yes. Usually the immunologic cascade happens seconds to minutes after Johnny eats a peanut. But let me get real with you. Careful, bro. That anaphylaxis is unpredictable. It could be not so scary, and then your endogenous adrenaline and angiotensin may cover it up. No prob, brah. Or it can smolder, look more like an allergic reaction, maybe some hives and maybe a little itchy throat, and then boom, full-blown anaphylaxis. No one can really safely predict the onset or duration of symptoms, which is why it's best practice to use this mantra. Could it be anaphylaxis? I stab you with epinephrine. Okay, so what about the dreaded biphasic reaction? A biphasic reaction happens when there is some inciting agent that causes anaphylaxis. Either your endogenous adrenaline counteracts it, or we treat it. You get better. But maybe there is still some of the IgE antigen complex floating around, just waiting to say hello to its new friend, the mast cell. This happens in about 15% of cases of anaphylaxis, the round 2. The biphasic reaction can happen within hours to days. From a practical standpoint, though, if you treat someone for non-life-threatening anaphylaxis and you watch them for a few hours, 2 hours, 4, 6, whatever you feel comfortable with, since no one really knows the right answer, you can give them a prescription for an epinephrine autoinjector. Give them 2, 4, or more prescriptions. For bad cases, you'll want one at the ready, at home, in the car, in mom's purse, at school. You get the idea. Now, granted, lately this has become an expensive endeavor, and it would depend on the situation. But everyone deserves good return precautions, exposure safety, and off they go. Of course, for the life-threatening anaphylaxis, I admit, citing the very real possibility of a biphasic reaction. Speaking of types of anaphylaxis, what other types should I know? Well, I'm glad you asked. Delayed anaphylaxis. We talked a little bit about this. Think hours more than minutes. Treat it just like a latecomer to the party. Stop. Epi time. Protracted anaphylaxis. This is an anaphylactic reaction that can last for hours or days. So, if someone comes in with hives and wheezing for the past 3 or 4 days, don't write it off as, it's just a virus. It can't be anaphylaxis. Keep it in mind. Protracted anaphylaxis. A special population I want to mention is infants. If you thought that identifying anaphylaxis in children and adults can be tricky, wait till you meet the biggest tricksters of them all. Infants. Okay, maybe that's not totally fair. If you're going to have an allergy to something, there has to be a first time for it. Often in infants, that first time is from some new food. And since no one would have known, their first sign of any allergy could be anaphylaxis. How does this translate into what we see? The infant comes in irritable, or pale, or vomiting with diarrhea profusely with a rash. You can see how anaphylaxis might not come to mind right away. Here's a case for you. A 10-month-old baby boy has a little eczema on his cheeks, no big deal. He's primarily breastfed. He's a healthy little chunky monkey. He gets some rice pudding today for the first time. Immediately, he gets swollen cheeks, lips, and tongue. He vomits a few times. Reportedly, he was irritable in the field, but as paramedics arrive with him, he is sleepy and maybe lethargic. He's tachycardic with a low oxygen saturation. You give O2, you give IM epinephrine, and 10 minutes later, he's awake. He's very upset, but his work of breathing is much better and the swelling is improving. He's no longer in extremis. He improved, he was admitted for observation, and the parents got really great follow-up. So, what was it? Maybe the egg in the pudding? Something else? The point here is that he may have just arrived lethargic, in shock. And what would we normally think? Sepsis, meningitis, drug ingestion, lots of things. But let's keep in mind that infants get anaphylaxis too, y'all. Let's talk treatment. Maybe it's best if we have a ramping up approach. Of course, for a mild allergic reaction, antihistamines and possibly a steroid, they'll often do the trick. Here, in anaphylaxis, we're talking epinephrine. Don't fear it. If the child's heart rate is high because of the anaphylaxis, you're not going to make his heart explode by giving him the potentially life-saving treatment of epinephrine. If an asthmatic is in status asthmaticus, you better believe his heart rate is high. Would you withhold beta agonists and maybe epinephrine? No. If you get the respiratory status better, everything else will follow. It's the same with epinephrine and anaphylaxis. Kind of like you gotta spend a little to make a little. Epinephrine's alpha-1 adrenergic agonist effects are what we really need here to increase vasoconstriction, increase peripheral vascular resistance. All of this will help direct forward flow and will also decrease mucosal edema and third spacing. Epinephrine's beta-1 adrenergic agonist effects will help cardiac output with increasing inotropy and increasing chronotropy. And finally, epinephrine's beta-2 adrenergic agonist effects will increase bronchodilation and hopefully shut down those troublemaking mast cells. All right, the safest, fastest way to get epinephrine into an adult or child is intramuscularly in the mid-lateral thigh. Even in the emergency department, the auto-injectors are much easier to deal with than drawing it up yourself. If you got them, just grab them. The auto-injectors come in 2 doses, junior and adult. For children 30 kilograms and more, use the regular auto-injector containing 0.3 milligrams of epinephrine. For children less than 30 kilograms, use the junior version containing half of that, 0.15 milligrams of epinephrine. Now, that's a big difference. But this dosing highlights a few practical principles in treatment. First, of course, is that no one really knows the perfect dosing regimen. Don't expect RCTs on this anytime soon. Second, it's always better to give a little more than you need. Slight overdoses are okay. Underdosing is not. To be a bit more exact, though, and what you may use in hospital, remember this dose, 0.01 milligrams per kilogram intramuscularly to the adult dose of 0.5 milligrams. Don't give epinephrine subcutaneously, since the absorption is slow and it's erratic, especially in a shocked patient. And remember, don't give this huge dose IV either. Give the IM epi 0.01 milligrams per kilogram up to the adult 0.5 milligrams of actual body weight. Well, what if the child, adolescent, or adult arrests because of his anaphylaxis? Well, then just give him the appropriate IV dose of epinephrine as you would have done for any arrest. Of course, airway is of great importance, but in this case, it's the epi that's going to make or break the encounter. Stick them with a pointy end, early and often. Still, it's smart to hyperoxygenate someone who's really in trouble for the shock state itself and to prepare for the disaster that may mean managing that airway. Due to facial and laryngeal edema, you may have to use fibroscopic techniques, or be ready to jet ventilate, or even perform cricothyroidotomy. Prepare, but let the epi work and be ready to act if needed. Anaphylaxis is a type of shock, distributive shock. So fluids can be your friend. But anaphylaxis also makes us leaky. We can transfer up to a third of our intravascular volume into the third space. By the way, we toss around those terms all the time. First base, second base, third base, home run. What does that even mean? In the circulatory system, the first space is the intracellular fluid, where the rubber hits the road. The second space is the extracellular fluid, the circulatory highway. The third space is the ditch on the side of the road, the tissues. Fluid in the third space is stuck until it's somehow compelled to get out of that ditch. Just think, a third of your circulatory volume can be out of circulation in anaphylaxis. Get that IV or IO and start pushing fluids, even before you think you need to. Now, early IM epi, even repeated as needed with IV fluids and supplemental oxygen, that is the cornerstone of anaphylaxis treatment. You may find yourself in a situation with protracted anaphylaxis or refractory shock. Here's what to do. First, double check that there isn't some exposure that still needs decontamination. Maybe a wasp stinger, maybe a liquid exposure on them, maybe a patch that still needs removal. Second, keep treating for anaphylaxis, but ask yourself, is this truly a distributive shock, or is it something else? Cardiogenic, maybe obstructive. And of course, now we go for the big guns. Epinephrine drip. In infants and children, start the epinephrine at 0.1 micrograms per kilogram per minute. You can rapidly titrate up every 1 to 2 minutes or so, up to 1 microgram per kilo per minute. Look for signs of better perfusion, like skin signs and improving mental status. The blood pressure, of course, should improve over the next few minutes. The heart rate, as you know, will still be high, so that we can't use that so much to see improvement in circulation as the drip goes on. You can use the dirty epi drip on anyone, of course, but if you have a minute, get the right concentration. If you have absolutely nothing, you can, of course, make it up. Nothing against that. But from a practical point of view, it may seem cool and cowboy, but in most hospitals, the pre-made or on-demand drip made by an experienced hand is a lot faster than convincing a nurse to hand you an ampule of epi while you stick it into a bag of saline, connect it, and use your best mood ring to figure out how to give it. All right, epi is great. Epi is king. So what could go wrong? There are minor things like anxiety, restlessness, headache, and just feeling spazzed out and messed up. Rarely will epi treatment for anaphylaxis cause dysrhythmias or ischemia. But always treat the whole patient. Does this patient have a history of intracranial aneurysm, of coiling, of clipping, of aortic disease or collagen vascular disease? Treat the patient, but just titrate carefully. Remember, we have to treat the life threat. Treat for that life threat, but with some judgment. Okay, so what if epi isn't enough? What? We just spent the better part of our time together extolling the virtues of Epi the Magnificent. But it is known. Any man who must say, "I am the king," is no true king. That said, what else should we be thinking about? If the patient is taking a beta blocker, think about glucagon. No amount of epi will counteract the beta blockade unless you deal with it. Glucagon has inotropic and chronotropic effects not mediated through beta receptors. In children, that's 30 micrograms per kilogram of glucagon over 5 minutes. You can start a drip if needed. In adults, that translates to a dose of glucagon of 1 to 5 milligrams slow IV push. We've maxed out our epinephrine drip. Not a great response. Well, what do you usually do when you are maxed out on a pressor? Well, you add a second. Vasopressin is the go-to vasopressor here in anaphylaxis. If you need to add a third one, you're really in trouble, but you could do norepinephrine as well. Do what you have to do to support perfusion rather than a specific number. Okay, so far, so terrible. What else? At this point, if you've maxed out your epinephrine, your vasopressin, etc., you likely have vasoplegia, profound vasodilation. Time to start getting all endothelial dysfunctional up in this piece. Methylene Blue, among many things, has a secret talent. It inhibits nitric oxide synthase. No NO, no vasoplegia. Methylene Blue is given 1 to 2 milligrams per kilogram over 30 minutes. The effect that you'll see is not going to be immediate, but when it's used, it can make a huge difference in the next fork in the road of treatment. Now, of course, we can't give methylene blue to people with pulmonary hypertension or G6PD deficiency. Otherwise, if the patient is not doing well, it's worth a shot. At this point, we're really starting to exhaust what we can do in the ED. Use this as an opportunity to get unstuck if there happens to be some anchoring bias. What else could this be? What else could be explaining the profound shock? Regardless, as long as there's perfusion, it may take time in anaphylaxis for the patient to improve. But there will be that case in which no matter what you do, you're just not winning. It's for those times you can think about Ecmo. If this is truly a reversible condition due to anaphylaxis, then you just need time. What is Ecmo good for? Well, it's not a destination, it's a bridge. It buys you time. Having said that, it can get really messy really fast trying to coordinate this, even if you have it already in-house. Just keep Ecmo in mind and do whatever you can up to that point. All right, now you're an anaphylaxis master. You can recognize it by the criteria, but you're not bound by them. You keep your wits about you and you give epi early and often, IM, and hopefully by autoinjector if you got it. You escalate care early and often, but you realize that sometimes you need to let the therapy just take effect. You rethink and you reframe and you do your best not to get stuck on early closure. You realize that although this may be a straightforward presentation, it is fraught with underdiagnosis, undertreatment, and underappreciation of just how sick these children and adults can get. And because of all of this, you're all the better for it. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.